thank you so much for being here and for joining us for the launch session of the Trauma-Informed and Healing-Centered Practice Training Program. Today's session, Trauma and Trauma-Informed Care 101, will be presented by one of our program partners, the Illinois ACEs Response Collaborative. My name is Courtney Cintron, Ingenuity's Partner Engagement Specialist, and I'm joined here today by Nicole Upton, Ingenuity's Director of Partnerships and Professional Learning. I think Nicole's on there somewhere, I'm gonna give you a wave. And I'm also joined here by Madison, today's facilitator, Madison Hammett, and Policy Analyst of the Illinois ACEs Response Collaborative. We've been planning for this program for quite some time now, and it's really humbling to finally be here. So thank you again for everyone joining us today. So the content and discussion in today's session and throughout this program will necessarily engage with trauma, and some of the content may be emotionally and intellectually challenging to engage with. Our session facilitator will flag the specific content and terminology that will be used in today's session, and then we'll have that same model moving forward. And we will do our best to make this virtual space a place where we can engage bravely, empathetically, and thoughtfully with challenging content. Okay, so with that, we would like to begin today's session with a land acknowledgement to recognize and honor Indigenous peoples as traditional stewards of this land, and it's a step toward correcting the practices that erase Indigenous peoples' history and culture, and toward inviting and honoring the truth. So we'd like to acknowledge that this virtual classroom is taking place on the stolen land of the Council of Three Fires, the Ojibwe, Potawatomi, and the Odawa nations. Many other tribes, such as the Miami, Ho-Chunk, Menominee, Sauk, and Fox, also called this area home. Because of the Great Lakes, the land naturally became a site of travel, healing, trade, and gathering for more than a dozen other Native tribes, and is still home to over 100,000 tribal members in the state of Illinois that still practice their traditions and care for this land. So these lands were the traditional birthright of Indigenous people who were forcibly removed and who have faced centuries of struggle for survival and identity in the wake of dispossession and genocide. So as we begin this program, let's take a moment to honor these ancestral grounds on which we stand and support the resilience and strength that all Indigenous people have shown worldwide, and also begin to rethink and reflect on our own relationship with the land and the original people of the land. Thank you. Actually, I think I'm gonna skip ahead to the program description, and then we'll come back to our session rooms. Thank you. So for those of you who are joining us for the first time, or who may not have heard about the full scope of this program, I'm going to talk a little bit about the program, its goals, and how it came together. And I'll drop a link into the chat to the program's webpage so that you can browse and follow along and register for any other upcoming sessions. So just give me one moment and I'll put that in there for us. Okay, there we go. Beautiful. So the Trauma-Informed and Healing-Centered Training Program for Arts Partners is bringing together a team of trauma-informed organizations and practitioners, including Chicago Growth Mindset, Illinois Collaboration on Youth, and Illinois ACEs Response Collaborative, and the Institute of Therapy Through the Arts, with the aim of providing arts partners with sector-wide assistance and capacity building and understanding, implementing, and advancing trauma-informed care and healing-centered principles and competencies into organizational and programmatic practice. And also to create the space for the sector to really consider how the role of arts and arts education can mitigate the impact of trauma and help students thrive. So the program has been conceived in two primary parts. Part one of the program, which starts today, will build a trauma-informed care and healing-centered knowledge base through a series of 13 trainings facilitated by the consortium of organizations. So the first 5 trainings are going to provide essential 101 topics, many of which speak to the current moment and also provide a launch pad to kind of get into the more specific and nuanced topics that you'll see a little bit later on. Today's session is one of those first 5, and we'll discuss topics such as the landmark Adverse Childhood Experiences study, how ACEs and other trauma can impact health across the life course, and how organizations and individuals can utilize trauma-informed principles to build resilience and promote thriving across a lifespan in their communities and workplaces. So after these initial 5 sessions, the program will then be divided into 2 learning tracks, one to meet the specific learning needs of arts organizations and the other to meet the learning needs of teaching artists, teachers, individuals. However, these sessions, although they're very specific, are also covering universal topics that will be beneficial for anyone in the sector and beyond. So registration for the organizational instructional sessions open today, December 1st. In that link that I previously shared with you, you can find where you can register for all of those upcoming sessions. And I'll share it again a little bit later. And there are no prerequisites for these classes, and you may select whichever ones that pertain most to your needs, and all of the sessions being offered are completely free. So that is wonderful. And then part 2 of the program is going to begin in March. And that part will include a series of collective impact sessions across artistic discipline, facilitated by members of the Institute for Therapy Through the Arts. And we'll host 2 working sessions for each arts discipline, including dance, music, theater and lit, and visual art, media art. Many partners are already doing this work, and this will provide an opportunity for collective knowledge sharing and co-sourcing of ideas. So then the program will finally culminate in a toolkit and guidebook that will include a comprehensive assessment mapped to the trainings, a number of resources from each of the sessions, and recorded video trainings so that we can share them with the people that were able to attend the sessions and then beyond. So you might be asking how all of this came together. The genesis of this project really started with the Arts Ed Response Collective. So the Arts Ed Response Collective, Ingenuity convened stakeholders across the arts ed sector, including CPS teachers, administrators, arts partners, students, and funders at the start of the pandemic to gain a better understanding of what their challenges were, and then to proactively and collectively think about how to mitigate some of those challenges and plan for the future. And what emerged was a clear need to understand the ways, once again, that art could be used as a tool for recovery and healing from crisis. And that became even more pressing as the ongoing violence against Black communities and the disparities around the virus came into focus and into the forefront. And there was also a need for authentic learning practices that would truly support professionals in expanding their practices. In the past, we've had more truncated sessions that maybe didn't provide the same kind of depth and breadth that this program is offering currently. But as an immediate response, Ingenuity initially started off with a shorter 3-part training series in partnership with the Illinois ACEs Response Collaborative. So they're joining us again now. But these trainings provided partners with an important introduction and foundation to trauma-informed principles and practices. We received a lot of great feedback from partners, and we wanted to build off of that initial work to create something that was even more dynamic and robust in nature. We also wanted a diverse group of facilitators with various approaches, various experiences and perspectives to meet the needs of our diverse partner communities. And now we're here. At day 1 of this program, we're truly privileged and humbled to have such a great team of collaborators and to be here embarking on this program with all of you. So before we get started, I'm just going to briefly go over some session norms. We've divided the session norms into a few different categories here. We're just going to navigate back there. Perfect. First, we have take space, make space. So as a participant, please be mindful of any privileged identities you may hold and help to create an environment for everyone to contribute. And we have speak from personal experience. So let's own our statements and views about things and not presume to be able to speak for others. For being in the moment, we have acknowledged the struggle of the times that we're in. This really means things are unpredictable and challenging right now, and things may not always go 100% as planned. So we ask that you have extra patience and flexibility during this time. And under how we show up for ourselves and each other, we have openness to learning. So an understanding that we're all learners in the space. And then use the chat box mindfully. When using the chat box, we ask that you try to make your questions and comments as relevant to what we're talking about as possible. And then finally, confidentiality. Take away lessons, but not personal content. We will sometimes knowledge share and co-share ideas or stories and resources in these sessions, but if anyone shares anything personal, we ask that you don't bring it out of the space. Okay, so without further ado, I'd like to hand it off to Madison Hammett, Policy Analyst of the Illinois ACEs Response Collaborative, to bring us through today's session. Thank you very much.
Thank you, Courtney, and hello, everyone. Thank you for having me and for joining us. I am going to jump right into introducing myself because I think it's always important to know who's talking to you and why I'm here. So like Courtney said, I'm Madison. I'm the Senior Policy Analyst and Training Manager with the Illinois ACEs Response Collaborative. And we are, as the name suggests, a statewide collaborative made up of all sectors. So folks from the healthcare, education, social services world, and now the arts world. We're so excited to have so many of y'all with us today. And we are dedicated to the idea of creating a trauma-informed Illinois and preventing trauma, promoting thriving across the lifespan. And we do that through, we have our three sectors that we work with here. So policy and advocacy, which is very much like the name sounds, but also includes little p policy. So we work with workplaces and different sectors to make trauma-informed schools, trauma-informed hospitals. How do we integrate these ideas into the workplace? As well as big P policy, legislature, working particularly with state legislature, but also with Senators Durbin and Duckworth on federal legislation. We also do capacity building, so that's what this is a part of. So items like trainings, but as well as pieces of information specific to different sectors, as well as if you are an organization that wants to become a trauma-informed organization, we do technical support around that. And then finally, research, translation, and dissemination, which is exactly what it sounds like. So now you know who's up here and why I'm here. And like I said, it's really about this idea of what does it mean to be a trauma-informed state? What strategic priorities should we emphasize? And how do we envision health and healing across Illinois today? And I bring these three questions up to y'all because like Courtney said, this is the first day of this program. And so I'm actually asking y'all these questions. And so as we go through this training and as y'all go through the subsequent trainings with our partners at ICOI and Chicago Growth Mindset, I would love to know more about what is it that you think the answers to these things are. So not to put anyone on the spot today. So but just keeping these things in mind as you move throughout this whole process that Ingenuity has set up. And then I do want to take a moment before we jump into content to do two notes. The first of which is Courtney has already touched on with a content warning. So this is a training about trauma, and this is a training where we are going to talk about not only how to address it, but also how it manifests and how it might appear, where it appears. And so I just really want to encourage folks to take care of themselves in the best way that they can and know how to do. And if that means turning off your video and taking a walk out of the room, if you need to leave and come back, please do so. I'm happy to share anything that you might miss. Some specific content warnings. We will be talking about child abuse, including physical and sexual abuse, talking about, however briefly, incidents of historical trauma, so racism, the Holocaust, genocide generally, talking about community violence, including police violence, talking about the isms, so racism, xenophobia, homophobia, hardships that different populations face. So again, if you, whatever way feels best, taking care of yourself, please, I encourage you to do so. And I'm happy to share anything that you might miss. And this also just includes taking care of yourself during a training. I know it's hard to stare at a computer screen for 2 hours straight. So if you need to get up and walk around, or, you know, go take care of a baby or a dog or a cat or yourself, please do that. And I'm happy again to share anything you might miss. And then I want to take a note or a minute to note the language I'll be using. So in this training, we do use the words trauma and resilience. We do that because those are the most commonly used in peer-reviewed literature, but you might use something different to describe these pieces of life. You might use words like adversity or thriving or something else, and those are absolutely fine. It's just what we have elected to use in our training based on this literature. I also want to take a note on the language I use is influenced by my identity and who I am. So I am a white cis woman. I am queer, I am disabled, I am from a rural working class background, and all of that informs who I am and how I give trainings and what I share. And so just taking a note that it's not only the scientific language we use or the peer-reviewed language we use, but also how our experiences shape our language and the information we process. And so wanting to acknowledge that and encourage y'all to share if you have any other pieces that you would like folks to know about in the chat box or in our question time. And then normally this is where I would make us all go around and do a very awkward icebreaker if we were all in person, and force you to think of like your favorite color and who you'd want to be on a desert island with or something like that. Rather than doing that, I know Courtney has already pointed out the chat box, so please introduce yourself. I'm also going to share my contact info at the end of this, and would love to hear from y'all if you want more information, you want to bring this training just to your organization, or you want handouts, happy to share that. And I'll also share a PDF of the slides at the end of the presentation in the chat box for everybody as well. Had something in there twice. I was so excited about it, apparently. And then here's just our agenda. So very quickly, gonna go over what is trauma and what is the ACEs study? What is trauma beyond that ACEs study? And how does this affect our biology? And then diving into what is resilience and what is trauma-informed care, and how can you integrate those into your daily practices? Our objectives for today, so very quickly, just defining trauma and discussing the ACEs test. You'll be able to hopefully understand how trauma can physically change our biology and our brains and how that impacts our health and well-being. We'll discuss what resilience is and how it can lessen the effects of trauma, and understand how to incorporate that knowledge into your work with patients, the community. We have teachers here. I know artists, so I use all of these in the broadest sense of the word, as well as in your own life at work and at home. And I do want to note too that we will have a break about halfway through as well for folks. So please take that break when you need it. So diving in, what is trauma? So very simply, trauma is a threatening or harmful physical or emotional experience to yourself or others. And the important thing about it is that it overwhelms our ability to cope, and it affects functioning in multiple domains. So here you have what we call the cycle of trauma. We say it's a cycle rather than a linear experience because these things don't happen in a very neatly packaged A happens, B happens, C happens, but rather they're all happening at once and together. And this comes in the form of the event. So what actually happened to you? You know, I was in a car crash. I survived child abuse. I had, you know, this traumatic experience, and that was what happened to me. That's my event. And then actually when we say experience, we don't mean that. What we mean is how we're experiencing, what's going on with our body in that moment, but then also after it. How is it making us feel, not only emotionally, but physically? What are the changes we notice? And then the effect. What are those changes doing to us? Have we changed our lifestyle? Have we, did we maybe walk down the street at night and now we won't do it anymore? Do we avoid a certain place? All of these things, that are sort of the side effects of trauma. But again, these don't all happen in a very neat linear line. Trauma is a cyclical experience for a lot of folks. And it's also something that is malleable. It can change. I thought I was okay, but maybe I'm not, or I thought this was really bad, but I've worked through it. And it's also relative. Everyone's experiences are different. And so really encouraging the idea, again, of this is not a linear, very neatly packaged experience for most folks. And we need to know about it for quite a few reasons. So as we're going to see coming up, trauma is incredibly common. You'll see not only in young adults or children, but throughout the life course, people have experienced trauma in huge rates in the United States. And we know from studies like the Adverse Childhood Experience studies and others that this is impacting the health and social outcomes of folks, both in their day-to-day lives, but also in the long term. We also know that trauma impacts everyone. It impacts you and your work and the individuals and communities you serve. And it impacts us, in multiple ways. We might be survivors of trauma, but also taking care of folks who are survivors. But we also know that this trauma can be prevented, addressed, and healed, that resilience building is possible. And just as trauma can change our bodies, so too can this resilience building. Because we know that, and this is a theme throughout this presentation that you're going to see, trauma isn't destiny. And I encourage you to really keep this in mind as we move forward, particularly in this first half, because you're going to see a lot of information and studies around, these are the things that happen with trauma. And I don't want folks to get discouraged by this information and think, well, that's some depressing information that now I can't really do anything about. And that's not true. We know that trauma isn't destiny, that through resilience building and through trauma-informed principles and practices, that we can change the outcomes, the health and social outcomes that people experience as a result of trauma. But before we dive in to how do we address this or what is resilience, we need to first kind of talk about the history behind all of this, and first talk about where did this idea come from. And trauma it's not a new idea, but when we talk about trauma now and when we talk about trauma-informed care, a lot of that has its origins in the Adverse Childhood Experiences study, which is a study that was conducted in the mid-90s by the Centers for Disease Control and Kaiser Permanente, which is a managed care organization in California. And it was at the behest of these two physicians, Dr. Robert Anda and Dr. Vincent Felitti. And they were on opposite ends of the country, but and didn't know each other, but found that they were coming to the same question independently and wanting to answer. And it seems really straightforward and simple of why is it that some of my patients, no matter what they do, get sick and suffer, and other patients, no matter what they do, seem fine? That, health behaviors don't seem to, have as much of an impact. And they came to this question through their work. Dr. Anda was running a smoking cessation study at the Centers for Disease Control in Atlanta. And so he was studying, not only why is it that people start smoking, but why is it difficult for folks to quit? Why is it difficult for folks to stay away from cigarettes if they have quit cigarettes? And he found in his patient population that those who had the hardest time quitting cigarettes, or those who would quit and then start smoking again, were also those that were reporting the highest rates of depression and anxiety. And so he started asking them more questions. When was it that you started smoking? when was it that you started having these symptoms of depression and anxiety? What was going on in your life that you started feeling this way? And found pretty repetitively across this patient population, repeatedly across this patient population, that those who had the hardest time staying away from cigarettes, so those who might have quit and then started smoking again, or those who had never quit at all, were not only the ones with the highest rates of depression and anxiety, but were also the ones that started smoking the earliest and reported feeling symptoms of depression and anxiety at very young ages, that also usually co-occurred with incidents of childhood trauma. Things like, I was abused as a child, or we didn't have enough food to eat, my father was arrested. And so he started thinking there had to be some sort of connection between this rate of childhood trauma and why people started smoking. And he didn't know it, but across the country, Dr. Vincent Felitti in California was actually coming to the same conclusion in an obesity study. Dr. Felitti ran an obesity clinic where people were trying to lose weight, and he tells the story of how his patients would lose weight and then hit plateaus, or they would lose the weight and reach their goals, but then gain it all back very quickly. And when Dr. Felitti tells the story of these patients, he is honest and says, I thought they were lying to me when they said, I'm following the diet plan. I'm doing all of the exercises that we discussed. I'm taking the medication you prescribed me. He said, they must have been lying, I thought, because if they were doing that, then they would be losing the weight and they'd be keeping it off, but they weren't. And so he started asking them, what's your diet look like? What's your exercise look like? But then he started asking them those same deeper questions that Dr. Ando was asking. When did you start gaining weight? What's going on in your life? What happened that you started perhaps using food as a self-medication? And he found, particularly in his female patients, a strong correlation with the first, big weight gain in their life and an incidence of childhood sexual abuse. That those who had experienced childhood sexual abuse were also the ones that were having the hardest time losing weight or keeping it off. And so he thought there had to be some sort of connection. Surviving childhood sexual abuse somehow makes it harder for women to lose weight, and it was his hypothesis. And Dr. Anda and Dr. Felitti were introduced to each other and, talked to each other and said, oh, we think that there's something to do with childhood trauma and these health behaviors, but we just don't know what it is. And they came together and conducted this study with more than 17,000 study participants in California. And what they found too is, and of this study population, what I think is most important is, so these were Kaiser Permanente patients. So these were patients that had access to healthcare, but they were also majority white. The majority of them were well educated. Most of them had college degrees. Almost all of them had high school diplomas. Most of them were employed. Most of them owned their own home, considered themselves middle class. And so these were folks too that were not being looked at for trauma. They were not a population that scientists considered, noteworthy or something that you would expect to see a lot of trauma in, because on paper they had everything that they needed. And so I think that's important too when we talk about the ACEs study, is to show, and how common trauma is to showcase that scientists were not looking for it. And if it's so common in this population, what must it be like in the folks that don't have all of these opportunities and advantages on paper? Because what they found was that trauma was incredibly common. And they found that through asking about 10 childhood traumas, and these are under 3 categories of abuse, neglect, and household stress. So physical abuse, where you ever hit, punched, kicked, or slapped as a child. Emotional abuse, did anyone ever tell you that you were stupid or they didn't love you, they called you names? And sexual abuse. Physical neglect, so did you ever feel like you didn't have enough food to eat? No one took you to school, you lived in a home that wasn't well maintained, emotional neglect, you felt like you weren't loved or well taken care of emotionally. And then they also asked about household stress, and these weren't things necessarily that were happening to the child, but were happening in the household. So mental illness, did anyone in your family have an untreated mental illness? Substance use, did anyone in your family have an untreated substance use disorder? Domestic violence, did you ever see a parent kicked, hit, slapped, or punched by a partner? Incarceration, was one of your parents ever incarcerated? And then parental separation or divorce. And these are the 10 original ACEs. Subsequent studies have included other questions or modified these questions slightly. Incarceration now is often phrased as detained by the state rather than incarcerated, because detained by the state includes arrest. Do you ever see a parent arrested? And it also includes children whose parents might have been deported or detained by ICE as well. So some variation in the questions, but these were the 10 original. And as I said, what they found was childhood trauma was incredibly common in this population. 60% of adults had one or more ACE, 25% had 3 or more, and 6% had 6 or more. And again, this was a population of well-off white people who had access to healthcare throughout their lives. And so these were not people that were interacting commonly with the criminal justice system or commonly interacting with the child welfare system either. And then they also found that accumulation of ACEs mattered. The higher number of ACEs a patient population has, the higher population risk they have, meaning that the more ACEs you have, there's a higher likelihood for diseases such as heart disease, cancer, mental illness. There's a higher risk for disability. And there's also a higher risk for what they called social and productivity issues. So you were less likely to have a job. You were more likely to have been divorced or involved in an abusive relationship, more likely to be struggling with substance use yourself. And then they found that not only were you at a higher risk for these illnesses or disabilities or diseases, but also that they were more likely to have an impact on your health as well. So you have ACEs and you have cancer, or you're more likely to be sicker than someone who doesn't have ACEs and has cancer. And they found that those with 6 or more ACEs were found to be at a risk for a shortened lifespan, 20 years less than those with no ACEs. So it's not only, impacting our day-to-day health, but it's robbing us potentially of 20 years of life. And if you are in a group of people where 6% have 6 or more, how many hundreds of thousands of years of life are we losing to childhood trauma, even years after the fact? And so that study right there, though it was somewhat narrow in its questions and looked only at those 10 original ACEs, it was really a jumping off point for examining childhood trauma and then examining trauma across the lifespan. They saw if childhood trauma had such an impact on this group of 17,000 people, what is childhood trauma doing throughout the country? And so there have been subsequent studies with those 10 original questions, even here in Illinois. And those results that they saw in that original study, 60% having 1 or more ACE, that's actually lines up with here in Illinois. Here in Illinois, it's about 58% have 1 or more, but interestingly, in Chicago, that number jumps up to 70% have 1 or more ACE. And that, I'm gonna go back, you see we have 6% have 6 or more. Here in Chicago, in Illinois, we do 5 or more, and 8% have 5 or more ACEs. And so there's an enormous burden of trauma here in Illinois and Chicago that reflects this original ACEs study. But we also know that these 10 original ACEs are not the only traumas that children and adults face, not only here in Chicago, but throughout the United States. And that's really where this original ACEs study has expanded to look beyond these original 10 ACEs and advance our understanding of adversity and trauma. So there's a lot of tree metaphors in trauma, I always say. This is the first of one that you'll see. And this was created by one of our partners, a Dr. Stan Sonu, who at the time was at the county hospital. And we share this because we want to share the idea that this is deeper and that these ACEs that we're going to talk about and the individual traumas that you might see with your students or the communities you work with, those aren't created in a vacuum, right? And so very much like this tree, ACEs are the leaves and branches, you know, they're very easily identifiable. You see them from far away. And they seem to, you know, be, if you ask what a trauma is, these are what a lot of people are able to identify with. But then we need to look beyond that and recognize that these are not created in a vacuum, that adverse community environments contribute to the creation of ACEs, contribute to households that are dealing with ACEs. And those are really the roots of this issue. Things like poverty, racism, housing discrimination, lack of educational and economic opportunity, community violence, including violence that people face from the state. So that's violence from the police, violence as a result of deportation, or you know, violence from the child welfare system. All of those count as, you know, these larger community violences inflicted upon people. But even that has its own origin, right? And it can't grow without soil. And that's where the idea of adverse collective historical experiences comes in. Slavery, genocide, mass incarceration, Holocaust, forced displacement, detainment, all of these have to exist, and they help this tree grow. Without these systems in place, all have a historical origin. And, you know, we say this in our historical trauma training, which I know is going to be available to y'all. These systems don't just disappear. You know, the people who created slavery, when the Emancipation Proclamation was signed, they didn't just poof out of existence. No, they were still in control and in power and just created new systems in place. Jim Crow came into existence, then mass incarceration to get free labor out of prisoners. All of these systems that we now live with even today all have their origins in a historical trauma. And so people who are living in communities today and dealing with adverse community environments and adverse childhood experiences are also dealing with the long ramifications of these adverse collective historical experiences. And then we also know too that these have ripple effects into how people take care of themselves in the workplace and how people take care of themselves when they are in their role is to take care of others, because you don't just stop being a person when you enter the workplace. And like I said, trauma is incredibly common. 60 to 70% of folks have at least one adverse childhood experience, not to mention all of these other collective experiences I've just noted. And so it stands, you know, it makes a lot of sense then that people are dealing with additional burdens and additional traumas like secondary trauma, compassion fatigue, and burnout. And these are all, they kind of get used interchangeably, particularly now. You know, this is obviously at the forefront of a lot of people's minds as we deal with COVID, as we all work remotely, as we figure out how to take care of our students, our clients, our communities from afar. And so I want to take this time to kind of separate these three ideas and showcase how they're different from each other, because without, you know, if we use them interchangeably, then we might use the response to them interchangeably, and that might not always be helpful. So secondary trauma happens when an individual hears about the traumatic experiences of another or witnesses them on television. While research on secondary trauma is emerging, one study has found that 75% of educators who responded have symptoms of secondary trauma within 3 years of starting their position. And this research is emerging, but as you can imagine, there's a heightened urgency for it in the wake of COVID, in the wake of the discussions around and protests around white supremacy in the United States and the world now. And so they've also started looking at people's personal histories of trauma here in this human service world, and up to 80% of human service professionals report having a personal history of trauma. And this includes folks who are educators, who are social workers, who work in community organizing, who work in community response. And so if you're coming into a workplace where you hear about people's trauma, or you are dealing with the effects of people's trauma, maybe your students aren't telling you, hey, this is what's going on in my house, but they are acting a certain way, or they're responding to situations like a traumatized person would, you are still carrying that burden. And so that cumulative toll of personal trauma and workplace trauma can combine and lead to compassion fatigue and burnout. And that in turn can create ripple effects of inflicting trauma, not only on communities, but also on each other and our coworkers, if we're managers, the people who report to us, and also in our personal lives. So if that trauma in professionals is left unaddressed, it can lead to compassion fatigue. And compassion fatigue is a preoccupation with absorbing trauma and emotional stresses of others, which then leads to a reduced ability to feel empathy. And so by that, we mean that if you are someone whose job it is to listen and to take care of others, and you are constantly hearing very hard stories, or you're constantly dealing with the effects of other folks' trauma, whether that be their behavior or the things they're telling you, or you just work or live in a community that faces systemic trauma, you feel a need and an urge to take that on, but our body can only take so much. And we're going to go into the biological and physiological effects later, but eventually it has to stop feeling so much. And it can lead to a reduced ability to feel empathy. So it becomes harder for you to sympathize and empathize with others, hardships and difficulties. But it also becomes harder for folks to feel joy and happiness at others' successes and others' joy, and your own successes and your own joy. And that reduced those reduced feelings and a low affect, all of those, and that reduced feelings of empathy. And 65% of educators report feeling symptoms of compassion fatigue in their work. It's harder for them to connect with students, it's harder for them to connect with parents, and it's harder for them to connect with each other and the community that they work in, because they feel like they're not getting support around the secondary trauma and the just day-to-day hardships that they're facing on the job. And all of this can then lead to burnout. So burnout is a very hot topic right now. I think there's quite a few books that have actually come out over the last couple of weeks about it, not only in relation to the pandemic, but also I know there's books around generational burnout, of people dealing with, economic situation, not just now, but of the last 20 years. And so it's a very, commonly used word, but when we talk about burnout in this context, we're talking about it strictly in a workplace setting. So burnout occurs over time, and it may not explicitly be linked to traumatic event or exposure, but it certainly is enhanced by these traumatic events and exposures. And also, I would argue that very often the things that lead to burnout, feeling unsupported at work, feeling overwhelmed at work, feeling like you cannot handle the work you've been given, or combined with what's going on in the outside world, our brain still processes that toxic stress as a traumatic event. And so going all the way back to that first slide of saying, you know, trauma is cyclical and it's relative. And I would argue that even if we say like, oh, I haven't been traumatized, I'm just really stressed out at work, your brain might not know the difference. And your brain might be feeling those effects the same way. So this burnout is a state of physical and mental exhaustion related to your workplace and environment, and it can lead to decreased feelings of commitment, feelings of cynicism towards your work and students, and incredibly high turnover. And we'll dive deeper into that in the resilience section, but burnout is one of the leading causes of leaving the education world for teachers and for folks who work in like after school programming. It's feeling like they cannot handle the work anymore and feeling unsupported by their organizations. And so if you think about things like test scores suffer when there's teacher turnover, after school programming suffers when there aren't enough workers to fill positions, when kids see a new person every month. If all of those things suffer, and then because of turnover, what are we then doing to prevent that turnover, to prevent that burnout that leads to turnover? And we can't escape now COVID and its effects, and how it's already having a huge effect on folks in the education world, in the after school world. And so they've already started releasing studies on this. In August, they found that 40% of teachers and education professionals have reported symptoms of burnout associated with the pandemic. And these are related to things like online learning, but also feeling, helpless when their students aren't around and they feel like they can't help their students. Their students report struggling with a subject and they aren't able to assist them in the ways they normally would. Their students might have felt like school was a reprieve from whatever was going on at home, and they can't get that anymore. And teachers and educators take on that burden more so when they're doing it virtually. 47% of social workers and other social service providers have reported burnout or symptoms of post-traumatic stress disorder related to the pandemic, again, for similar reasons, taking on additional burdens. And then I think this is especially noteworthy, Black and Latinx, this is medical and education, professionals reported higher levels of burnout than their white peers, especially in the wake of the racial justice protests we've seen since the murders of George Floyd and Breonna Taylor. And they report this because they feel like they're not only dealing with this additional stress from the outside world, but of course we know that bleeds into our professional lives, but then feeling like their white peers don't understand them, aren't able to connect, and then reported feeling additional burdens of having to take care of junior staff, of feeling like they need to protect other Black and Latinx employees, and also the communities they serve, and knowing that a lot of their coworkers don't look like the communities they serve and may not understand what their students or clients need. And so they feel an additional burden to take on that role. And they called this the invisible tax of working. So COVID has already, created some of this, but it's also just exacerbated what was already present in a lot of organizations. And, as we hurtle into, another month where the numbers are only, rising, and there's still a lot of confusion around remote learning, and still a lot of confusion around what the best responses are, and there's fatigue around that response. They only expect these numbers to rise if educators, if the folks working at organizations aren't taken care of by their employers, who themselves are struggling on how do I take care of people over Zoom? How do I help people with something that I don't know anything about myself? So So I'm going to get us started in on the last half of our presentation and go into the biology of trauma and resilience, and then also how to actually integrate these ideas into your work, or at least get started with this. So we've already touched a lot on this first section of the biology of trauma and how it affects us. But we always think it's really important to talk about this element in particular, because it's not just, I think it's something that a lot of people, it makes sense for them. Oh, you had, a hard thing happen to you in your childhood, so you smoke more, or you drink more. But it's not just about that. It's also, you had a hard thing happen to you and it's physically changed your body. And so when we have this biological adaptation run into society's expectations, that's where a lot of the things that we call, maladaptive behaviors, or, even just like bad behavior, you're a bad kid. That's what a lot of that is running into, is that adaptation versus expectation. And so we include this section, even though, I'm not a doctor, and I don't think there are any doctors joining us today, because we think it's still really important for folks to know that this isn't just, in your head, that this is something that changes you. And thus, when we respond to it, we need to respond to it like something that is biological, and not someone just purposefully, subverting behaviors or expectations in public. So, and again, I preface this all by reemphasizing I am not a physician or a nurse. I'm a social worker. But I will say, if you're very interested in this element of the presentation, we have physicians and nurses on our staff and collaborative who are more than happy to give you a very in-depth, more than you would ever want, rundown of the neurobiology behind this. So we touched on this a little bit already, but our brains, particularly in early childhood, are sponges, and they are learning new things every single day. I always ask people, when's the best time to learn a language? And people always say, oh, when you're 5. Yeah, and that's exactly true, because our brains are learning so much of information and absorbing so much information from a very, very early age, and they're figuring out what to do with that information. So that's why toddlers are always such reasonable, well-behaved human beings, because their brains are doing so much work, and why nap time is so important. But the thing that we're all born with is this idea of survival, the survival state. Am I safe? And that's our very basic instincts. Do I have enough to eat? Do I, feel like I'm not physically threatened right now by the outside world? Am I warm? Am I comfortable? Am I going to physically survive what is happening to me right now? And that is our most basic instinct that we are born with. And that's unthinking in many respects. We breathe without thinking about it. Our heart beats without us telling it to. So our body is constantly trying to keep us alive. And then beyond that is when we start getting into more complex ideas of, am I loved? This emotional state. And, that's when we're forming relationships. Who is it that loves us and is going to take care of us? Our parents, our grandparents, our guardians, aunties, uncles, who is around us that's going to keep us safe and well protected. And then as we get older, friendships, romantic relationships, all of these are really complex ideas that really just boil down to this simple idea, though, of, am I loved? Am I well taken care of emotionally? And then the more advanced stage then is what we call our thinking brain. Am I thinking clearly? And these are the things that we need to do to get us from through our day-to-day tasks. Am I able to, do the things I need to do to get through the day. Am I able to go to work? Am I able to drive the car to get to work or get on the train to go to work? Do I know what to do when I get to work? Do I remember to pay my bills with the money I get from work? All of these things that, go into us having a well-rounded, healthy day are actually really hard. And we're actually doing a lot of work to remember those things. So if our most basic instinct, though, of survival, if a person feels unsafe and feels like they are threatened, they cannot then get to these more advanced levels or these more advanced stages of the emotional thinking of, am I loved? Does this person care about me? And then thinking brain, am I doing what I need to do? Am I thinking clearly? It's harder to focus or learn. It's harder to self-regulate. So back to that emotional state of, is this an appropriate emotional response to this situation in front of me? It's much harder for us to figure out those different questions that are actually really complex and that we learn at a really young age. And so when the processes of our brain become dysregulated or interrupted continuously in early childhood and throughout childhood, that's what can lead to those developmental delays and diseases that they saw in the ACEs study. And that's also why it's so important then to really emphasize particularly those two quote unquote bottom stages of survival and emotional. Are we making people feel safe? Are we making people feel loved? Because without those, they're not going to be able to get to the point of, am I thinking clearly? And that's because of something I'm sure a lot of not all of you have heard of the fight, flight, or freeze instinct. And it is something that I think a lot of us learn about very early on, but we don't learn about how important this is and how influential it is in our everyday behavior too, because we tend to think of it as something as a response to a big dramatic event, but actually our brain is constantly figuring out fight, flight, or freeze. And then recently I've actually been introduced to the idea of fawn as a response to needing to survive. So I'll go into that one in a second. But this response is adaptive in emergencies, but these emergencies can be big or little. And in stressful events, two hormones are released, adrenaline and cortisol. We need these to figure out, like, what do I got to do? This is a really stressful situation. How do I get through it? And this is good. We need stress. Stress helps us get through the day. It helps us, get to work on time. It helps us turn in our assignments. It helps us pay our bills on time, figure out like, oh, it's my anniversary, so I've got to make sure I buy a present for my partner. All of these like little everyday things are actually the results of stress and our body figuring out what's the appropriate response to this stress. The problem is when we have too much of that good thing. A healthy response to stress can have a negative impact if a body is exposed to these stress hormones for too long or too often. So if you're constantly being placed under an enormous amount of stress and your body's having to pump itself full of adrenaline and cortisol, and you're constantly having to figure out how to respond to these big situations, eventually that becomes its own wear and tear on your body. Your body can't keep doing that without damaging itself. And with that chronic and repeated stress, that stress response can either kick in more easily for perceived threats, so it doesn't require it, and that's where we get that fight instinct. People are hyper aroused and they have a hair trigger temper, or it might not kick in at all. And their body just says like, oh, I'm tired. I can't keep doing it. And and they get stuck and they don't respond to stress and they freeze in a situation that doesn't require it. And then there's also the idea too, like I mentioned earlier, of fawn. People who respond to stress by trying to appease the stressor, by making, platitudes or promises, or trying to calm down the stressor through promises of change behavior. And that's actually particularly common in children who have survived abuse. They're learning that if I am stressed out and I'm responding to these stress hormones, the way that I survive is by appeasing the source of that stress. But then they, again, like somebody who might have a hair trigger temper when it doesn't require it, or someone who doesn't feel urgency when it might require it, they then might fall into that pattern of, I'm stressed out, so let me try and appease you, even if it's not appropriate, or it's not needed in this situation. But that response is immediate and instinctive. People cannot control it. And so it then becomes very difficult to tell those people then, or tell anyone, hey, just calm down, like it's okay, you don't need to act like that, because people can't control it. And we've already touched on this, that then becomes toxic. We need stress to survive, like I said, but too much of that good thing can have detrimental effects on our health. Our bodies become adapted to a state of stress and not only suffer the side effects, but then find it difficult or impossible to discharge that stress, to calm down. And so you can get stuck in a hyper-aroused state. And here you see the symptoms of that, things like anxiety, panic, hyperactivity, also, physical symptoms that we may not necessarily see, on the outside world, but people are still experiencing, things like digestive issues, chronic pain, sleeplessness. All of these things are from being stuck in that hyper-aroused state of not being able to regulate yourself back down. But then people can also get stuck in a hypo-aroused state, depression, flat affect, chronic fatigue and exhaustion, disorientation, and emotionally finding it, difficult to connect, or having episodes of disassociation, and then also having low blood pressure, chronic pain that's inexplicable. They can't find an origin for it, poor digestive issues. So if you think back to all of those problems that people were facing with that original ACEs test, think about the stress and the physical effects that that's having on your body. If your body is constantly under stress and being worn down by that stress, and then feeling the physical side effects of that stress, it becomes that much more difficult to do its job, to keep you safe from disease, to keep you healthy, because it's having to do all of this extra work to keep you safe from perceived or from real threats. But we know that trauma doesn't equal destiny. So I have now just given you about an hour and 15 minutes worth of very intense, somewhat depressing, hard to hear statistics. And this is where I circle back to the idea that trauma doesn't equal destiny, that the things that you heard today, they can be addressed and they can be mitigated and prevented. And that's through trauma-informed principles and through programs like the one that Ingenuity is starting today and continuing throughout the rest of the year and into 2021, of how do you incorporate the idea of trauma-informed principles and resilience into your work? How do you make sure that you can be a mitigator or preventer of trauma, not only in the students you serve, but in their families and community as a whole, but then also as coworkers and as potentially managers or supervisors of other folks as well. And that is where the trauma-informed approach and resilience building comes in. So now we get to go on the up. So these are for healthcare organizations, but they are applicable to education and after-school programming, because all of this is applicable widespread. Healthcare benefits from being the sector where people have poured a lot of money into figuring out prevention and burnout response and that sort of thing. But I wanted to share this because I think it's still really important because this is all true in y'all's work as well. Turnover costs organizations a lot of money. And so I know I touched on this already, but if you have, a doubter in your organization or somebody that maybe doesn't connect with the more emotional side of trauma and wanting to help, I think that some of these numbers still show like it's incredibly important to address this in organizations. Training new employees costs all organizations on average an additional $20,000 per employee. So it's an enormous amount of money. Increased tardiness and absenteeism cost organizations nationwide $84 billion a year. So if you're thinking about those folks who, like I said, were stuck in hypoarousal and it's hard for them to get out of bed, they suffer from chronic fatigue, they suffer from digestive issues and they feel sick all the time. It's much harder for them to get to work on time. Think of how much money and manpower that can cost an organization. And this one, again, is more specific to the medical industry, but I do think it's also applicable in education. Secondary trauma and burnout is associated with major medical errors, medical malpractice suits, and healthcare associated infections. And that's because people are making more mistakes. And so if you are stressed out and you are burnt out, it is that much easier for you to make a mistake. But think about that in the education world too. If you're making mistakes as an educator, or if you are a supervisor and you're in charge of someone's well-being as your employer, your staff member, and you yourself are dealing with secondary trauma or burnout, what sort of mistakes in those interactions can you be making? Or what sort of things might you be overlooking because you're stressed out and you've got all of these things to deal with and you're dealing with your own burnout issues and your own secondary trauma. And so it's much harder for you to prevent compassion fatigue in yourself. And that's what we've seen pretty conclusively across the board in the medical world, but I'd argue that we see that pretty conclusively across the board in the social service and education world as well. If we, think back to those studies I cited about educators and social service providers leaving their industry because they're burnt out, because they have compassion fatigue, because they can't handle it anymore, what sort of mistakes or what sort of missed connections were there before they left the sector. And again, this is actually a statistic down here at the bottom for all, this is numerous sectors, but I referenced this already. Black and Latino professionals leave their jobs 24% more often than their white peers. And reasons cited include the burnout that we've spoken about and that invisible tax of feeling like they have to do feeling like they have an additional workload of, mentoring younger peers that their white peers aren't capable of mentoring, taking care of communities that are looked down upon by their white peers, feeling like they have an additional burden to represent Black or Latinx communities as a professional because their white peers or their white supervisors don't view them as professionals and aren't capable or well equipped to address racism within the organization or are unwilling to address racism and equity issues in an organization. And so all of that contributes to this additional burnout and additional secondary trauma, which then in turn leads to Black and Latino professionals leaving their industry. And we know that children, Black and Latinx children do better in school when they have Black and Latinx teachers, professionals taking care of them. They score higher on tests. They are less likely to be the victims of implicit or explicit educational biases. And when you watch our historical and structural trauma training, hopefully you'll see we do a deeper dive into those implicit biases and how they impact test scores and outcomes, educational outcomes. And so if we're making it harder for Black and Latinx professionals to work, we are in turn making it harder for Black and Latinx students to learn and thrive. And so that's all said with the importance, to emphasize the importance of this idea of resilience. And I think resilience is another term that gets thrown around a lot and is sometimes viewed, not necessarily in a negative way, but people view it as very individualized. Like, oh, we tell people they have to have resilience. Well, what does that mean? And that's not actually what we at the collaborative, and we hope that y'all will walk away with this, because we believe that resilience is actually community based, and that it's not one person has resilience and another person doesn't, but rather how do we all work together to create resilience with each other. And so resilience is adapting in the face of adversities, using, and this is important, mechanisms that don't cause further harm to your health and well-being. So if we look back at that original ACEs study with Dr. Anda and Dr. Filiti, their patients were trying to adapt to adversity, but they were using mechanisms that were impacting their health. They were smoking, they were, not exercising, or not utilizing self-medication, and that was causing further harm to health and well-being. But I say that with the caveat that there is no maladaptive behavior in this idea. I don't like that idea. We at the collaborative don't like that idea, because when we say that something's a maladaptive behavior, we are assigning a value to it. We are saying, you're bad for doing that behavior. It may not be what we intend, but the word mal does mean bad. And so we emphasize that there are no maladaptive behaviors. Rather, there are adaptive behaviors that can cause harm to our physical self, or might be considered inappropriate for an environment that we're in. But we should not be saying like, that's a bad adaptation, that's a bad behavior, but rather saying, what's going on that's the only behavior you have access, or the only adaptation you have access to? Why is it that, to treat depression and anxiety, Dr. Anda's patients only had cigarettes to help them alleviate their depression and anxiety? Why didn't they have mental health care to help them get through that? Why didn't they have a social service provider to help them get through that? Arts education to help them process? And so that's why we discourage this idea of maladaptive behaviors, but rather recognizing that everyone is utilizing the toolbox that they are given. And our role is not to judge those tools, but rather introduce new tools into the toolbox. And that's where building resilience comes in. And resilience is not something that is a moral judgment. It doesn't mean you're better if you're resilient. You're not a better or stronger person. Nor are you a bad or weak person. And it doesn't mean, though, that if you have it, then that your trauma is, not non-existent, or it's not important anymore. But it does mean that you've been given, again, those tools in your toolbox to figure out how to address it. And just like trauma, it's seen and experienced along a continuum, and it is variable. It's different for you than it is for me, and it is for, the person down the street. And it's not something that someone either has or doesn't have. You're not born with so much resilience, and if you've depleted it all, you don't have any more, or you can't grow or you can't learn. It can be taught and harnessed and nurtured throughout the lifespan. And so that's really where the role of trauma-informed practices come in. And so how do you do that? You do that through the idea of trauma-informed care principles, or TICP. So an organization utilizing TICP understands and considers the pervasive nature of trauma and promotes environments of healing and recovery, rather than practices and services that may inadvertently re-traumatize. And we'll dive deeper into this with our 4 R's. But one of the things that a lot of people, when they hear trauma-informed principles or practices, one thing I hear a lot is, I'm not a social worker, I'm not a psychologist, I don't want somebody to tell me something really hard and I don't know what to do with it, or I don't want to inadvertently re-traumatize somebody. And, I'm jumping ahead a little bit here with this idea, but I think it's really important. The purpose of trauma-informed care principles is not to provide psychological care to those who have experienced trauma. We're not asking folks, if they are not equipped to say, like, tell me all of these really awful things that happened to you in your childhood. Let's do an ACEs screener together. Let's do a depression screener together. That's not what we're saying we want folks to do. Rather, we're saying we want folks to recognize that trauma is incredibly common. You know, going back to that ACEs study, 60 to 70% have at least one ACE, and that doesn't capture all of the other social and structural traumas that face. So rather than, you know, asking each individual person, what's the traumatic experience that I need to address with you? That's not what we're saying. We're saying it's so common that by implementing these trauma-informed care principles, you're going to capture those folks and you're going to take care of them. And for those folks who haven't experienced trauma, these are still great ways to make them feel safe and accepted and help build resilience in them. So if they do one day face trauma, or they do one day face, you know, bump up against the secondary trauma or burnout or all of these other things we talked about that can happen in a workplace, if they're bumping up against that, they work at a place that has given them the tools to address that. And you're doing that by realizing the direct impact that trauma has, not only on communities, but also on staff. And you're also recognizing that it has the impact that has on accessing services, and you're responding to that, you know, changing policies, procedures, practices to minimize those barriers. So it's not about, why didn't you show up for your appointment? Or we had class this afternoon and you didn't come, you know, you can't come here anymore. More so asking, what's going on that made it hard for you to come to class today? Or what's going on that's making it difficult for you to turn in your assignments on time? Asking questions around that and recognizing that there are barriers to that are impacting people's ability to, again, behave in that expected way. It's that adaptation versus expectation. And you're integrating this knowledge into all aspects, and you're training all staff to recognize signs and symptoms of trauma and avoid re-traumatization. It's not just about teachers or social workers, or even not just about the folks that are doing that direct service or that direct interaction with kids or their parents, but also who's the first person they talk to when they call the organization? Is it a receptionist? Is it an admin? Do they see a security guard when they walk into the organization? Are all of these folks also trained in this trauma-informed and resilience building education work? And are they trained in this? And this is, I think, if you take nothing else away from this, I hope you'll take this idea of shifting your perspective from what's wrong with you to what happened to you. When we say what's wrong with you, even if we mean it in a, you know, in a caring way, even if we are just trying to get to the root of the problem, we are, however inadvertently, still saying there is something wrong with you. There is something bad about you. And that's not what we want to do. Going back to that idea again of no maladaptive behaviors, only adaptive behaviors. And so we want to shift that idea into what's wrong with you to what happened to you. What's going on that this is the response I'm getting when I say, hey, you need to sit down in the classroom, or hey, you didn't show up for work on time today. What's going on? That's what we need to shift our language into, because when we say what's wrong with you, we're saying what's bad about you. But when we ask what happened to you, then that leads into more questions like what's right with you? So what strengths are people bringing to the table? What ideas are people bringing to the table? What matters to you? What's important? You know, what are your values? And is this organization, is this work reflecting that? And then what can we accomplish together? And you'll see throughout this next section, you know, this is incredibly important, this idea of collaboration and shared power, not only with the people we serve, not only with our students or our clients, but also with the people we work with as managers or supervisors, and then as coworkers as well. So what can we accomplish together? And removing this idea that there is something wrong with somebody, but rather something has happened. And I want to help you get through whatever it is that has happened that is creating this conflict, whether it be, you know, not showing up for work on time or skipping out on class or causing a conflict in class. I want to get through whatever it is that is causing this rather than just, pushing blame on you for acting in a way that is not accepted in this classroom or in this space. And this is one of the handouts that I'll, on the handout that I'll be sharing with folks, there's a link to this in more in depth, but this comes from SAMHSA, which is the Substance Abuse and Mental Health Systems Administration, which is a very long title, so hence SAMHSA. And they have some really great guidelines on the trauma-informed approach for organizations, but it really just boils down to these 4 R's. So again, this is another thing that if you take nothing else away, maybe hopefully you'll remember at least the 4 R's, and that is realizing the prevalence of trauma, which we've touched on extensively already, and how common it is. Recognizing that trauma affects individuals, all individuals, and that includes its own workforce within a program, organization, or system. So even if you are not a survivor of trauma, you are still affected by trauma because somebody you work with is probably a survivor of trauma. Somebody you serve is probably a survivor of trauma. So you are still affected by trauma. You respond by putting that knowledge into practice. It's not just enough to, go to a training and learn some things, but what are you doing to actually address trauma and actually respond to how common it is? And you're working on resisting re-traumatization of clients and staff. That's again, another hugely important thing. You cannot be of an organization that says we provide trauma-informed services to community members if your staff is also not being taken care of in that same trauma-informed framework. So to that end, here are these have all been studied in various social service organizations that have worked on providing those trauma, building resilience and responding to trauma and trying to mitigate secondary trauma. They may not all be applicable to you. You may not be able to do every single one of them, but I present these more so to show that these have been studied. All of these were implemented at a social service organization in New York that it's quite a large one. It had about 1,000 employees. And they implemented all of these, and they saw not only tardiness and absenteeism go down, but they also saw health benefits. Employees who were part of the study had their blood pressure measured before implementing these. They had it measured 6 months in, and then they had it measured a year after, and they saw a continuous decrease in high blood pressure amongst employees. They also issued depression and anxiety screeners at the beginning of this study and at the end, and they saw rates of depression and anxiety decrease in employees. And so they not only saw like a healthier workplace, but they saw healthier individuals. And so that's really speaks to how even just simple resilience building over 6 months or a year can really impact how employees and staff feel, and in turn, how they take care of clients, students, and the community. So again, these may not be all applicable to your organization, may not be something you're able to do, but things to consider include limiting work hours and offering flexible working arrangements. I think this is particularly important here in the, I know this phrase gets thrown around a lot, in these uncertain times or in these unprecedented times, but I do think that's incredibly important. And when we say offer flexible work arrangements, if you may not be able, you may say like, hey, we've got to be here 9 to 5 because that's when our students can come, or we've got to be here, 3 to 7 because that's when they're done with their online learning. So then they come to us afterwards. But then it's more so about for your employees who have kids, are they able to, maybe start a little bit later in the day to get their kids started on online learning? Can they take a break to have lunch? And maybe people without kids too, did they have time to go and take a walk around the block? All of these things that seem really small actually do add up to this idea of flexible work arrangements, feeling like they're taken care of and saying, like, hey, I've got a doctor's appointment coming up. I've got to go to it. And that seems very like straightforward, but a lot of places don't actually offer that and don't offer this flexibility. But that goes into that idea of shared power of saying like, hey, this is important to me and I need it to be respected by my office. Can you help me address it? And that goes back to that idea of what matters to you. Investing in leadership development of supervisors who actively listen to staff and offer shared decision making. So it's, again, not just about coming to a trauma-informed principles training, or it's not just about learning about trauma, but it's also learning about how do supervisors talk to staff? How do supervisors view staff? Do you have a time of reflective supervision where folks can say, air grievances or come with concerns and feel like they're being respected and listened to? Is this a regular occurrence too? And that's particularly important, that regularity, that consistency. It doesn't have to be every day or even every week, but once a month. Is there some time where staff can gather together and say, like, this is what's going on and I need you to help me work through this, that reflective supervision. And also for supervisors to ask staff, say, hey, what's going on with your students? What's going on with your clients? What's going on with parents? Talk to me about, these difficult things that you might be experiencing. And that doesn't have to be, again, a very in-depth, trauma-informed, trauma-revealing session. You're not asking your staff to reveal sensitive personal information about themselves, but rather say like, hey, what's really important to you right now? What are you struggling to get through with, and how can I help with that? Creating a wellness committee with a wellness champion in that toolbox. So hosting wellness activities at work. I know this in times of Zoom is particularly difficulty because Zoom fatigue is real as well. But, are you checking in on each other? Are there things like, we all went for a hike together, or we all give employees one day off a month to do something like yoga, or spend time with their kids, or just take a day where they are encouraged to focus on self-care, on wellness. All of these are individual practices that you can do. And that wellness committee too, it's not just for supervisors, it's not just for managerial staff, it's also for people who might be interns or might be volunteers. All of these people have ideas and leadership qualities to contribute. And also, if you're an organization that has mental health care on staff, that has social workers or psychologists or anyone like that, I also really encourage that this not be only their responsibility, because again, if it is both for leadership reasons and for contribution reasons, everyone's got something to share. But I think too, if we say wellness is the mental health folks' role, that's their job, it allows us to separate it from everyone else's. And, if we say wellness belongs to mental health, does wellness not then also belong to our security guard? Does it not belong to the artists who maybe only work with us once a week to teach a class? Does it not belong to the administrators? Does it not belong to our accountant? Wellness belongs to everyone. And so if you are someone that has mental health folks on staff, I certainly include them and seek their knowledge, but I would definitely encourage for it not to be only their purview. And then establishing that wellness as a quality indicator for the organization. And this was really key in this study of not only measuring like within the study, but also to show leadership, this is what's going right and this is what's not going right. If you don't know what your employees or what your staff or what your community is responding to, you can't make it better. You can't make things more applicable. You can't respond to the current moment that people are living in, if you're not asking, if you're not checking in on folks. And so it's not, again, enough to just say like, oh, well, we're a trauma-informed organization and we care about wellness and, we'll check back in 5 years or 10 years and say, but in the meantime, just keep saying, oh, we care about wellness and we care about trauma-informed principles. It has to be something that's being continuously checked in on and continuously nurtured as well. And ways that has been done too, these have all been measured with how they impacted outside social service providers' work. So they looked internally and then measured client and community satisfaction afterwards. And they saw an increase in client satisfaction with the services being provided after these pieces were implemented in social service organizations. So facilitated discussion groups incorporating elements of mindfulness, reflection, shared experience, small group learning. And this doesn't have to be a super regular thing. It could be once a month, but just knowing that is there, even if it wasn't the week to do it, that already helped with employees' feelings of commitment and feeling like they were being listened to. Establishing a culture that prioritizes all relationships and teamwork. And again, going back to the idea of siloing and saying like, oh, well, this is what the managers do, and this is what staff does, and this is what volunteers do, and we, all have our roles. I'm certainly not encouraging you to upend your whole organization, but rather, again, look at that shared knowledge, that shared power. What can people who are entry level teach managers? What can volunteers teach staff? What can community members teach staff? And recognizing that these relationships, while there might be some elements of titles and a hierarchy that is inherent in a lot of workplaces, it doesn't necessarily have to be definite power arrangements, and that we all can bring something to that table. Supporting expressions of compassion and reducing stigma around emotional support. And I think this is particularly important because it ties back in again with that idea of it's not just enough to say that something is available and say that, oh, we're a trauma-informed organization, we have flexible vacation, take it whenever you need. But then if you don't model that, your employees aren't going to take advantage of it. If you are someone that says, or if you're an organization that doesn't encourage people to take time when they need it and then follow through with that, meaning you don't say even little things like, oh, well, Madison's taking a week off next week, so we're really going to have to pick up the slack while she's gone. You may not think very much of that, but what that's telegraphing is, you're taking the time off for yourself, and now we've got to handle it. And so it discourages people from taking advantage of the things that you want as part of your wellness and part of your trauma-informed principles. And so it's really important to model acceptance and good behavior around these pieces brought up. And also expressions of compassion too, telling people the phrase, it's okay to not be okay. That's true for staff too. So are you encouraging your staff to come to you, your volunteers to come to you when they're really struggling, particularly now as we all try and figure out how to operate in this virtual world and do things very differently than we were a year ago and are still really uncertain. So are you judging that? However, again, unintentionally by saying like, yeah, well, we're all dealing with really tough stuff right now. Or are you saying like, I want you to come to me and talk to me, and then I'm going to respond to it by saying like, take the day off tomorrow, or, if you need to take some time, that's fine. And really modeling that behavior and asking people, what can we do to support you right now? And then I think, particularly important, prioritizing and centering racial equity and justice. Trauma-informed care does not exist without racial justice. I've already, touched on some of the statistics around increased burnout, increased secondary trauma in Black and Latinx and other people of color in the workplace. And you're certainly going to hear more about that in subsequent trainings, particularly I know from our partners at ICOI. But it cannot exist without racial equity. If you are an organization that is not prioritizing racial equity, you cannot prioritize trauma-informed care, because it means that you're discounting the unique experiences of employees of color and how those contribute to trauma and how those contribute to burnout and secondary stressors. And so if you're saying like, you know, oh, well, everyone, we have a wellness committee and we're doing all of this stuff and, you know, that sort of thing, but then you're not also looking at diversity and equity and inclusion, then you're only going halfway. And so, you know, we're certainly not a DEI training, particularly this one, but I encourage those of you who are really committed to integrating these trauma-informed principles to also look at racial equity trainings and DEI trainings, because without those, you're only meeting a surface level of concerns for a group of employees who face additional trauma and stressors potentially, not only, from the outside world, but also potentially at work through microaggressions and biases at work. So you cannot separate trauma-informed principles from racial equity. And this is, we're gonna wrap up with just these 5 principles or practices. I'm gonna drop in the chat a handout that we developed with more specific like actual steps that you can take. And we've already touched on a lot of these already, but this is working with communities. So establishing safety, and that's both emotional and physical safety. You know, is your room someplace that people feel safe coming into? Is your virtual room someplace people feel safe? Courtney did a great job of establishing that safety at the beginning of this by, you know, giving norms and saying this is how we talk to each other here and how we respect each other. And so are you doing that when you interact with the community? Being trustworthy, so not making promises that you can't keep, which seems very you know, self-explanatory, but I think a lot of people in the service industry or in the social service industry and education industries and people who serve the community, we want to help and we want to do our best to do that, but it's better to be honest and upfront and tell people not make promises that we can't keep, and also involving people in those processes and making sure that they're a part of the discussion. And that's where providing choice comes in. And when we say providing choice, we're not just saying, you know, like, oh, you know, tell them they can do whatever they want. And, you know, if you have a kid that comes in and he wants to tear up a room, or he doesn't want to do the work or that sort of thing, you know, it's not necessarily saying to upend your whole program, but rather giving people like an option and saying, this is what will happen if you decide to do option A, and this is what will happen if you decide to do option B, and then being non-judgmental about that. And it may not be, you know, the best choices. It may not be something that people want to choose between, but rather it is, but what it is doing is it's providing choice. It's giving people the power to say no. It's giving people the power to be involved in a program or in a conversation or in, you know, a community, whatever it is. And again, it may have results that are not ideal, but what it is doing is saying you have the power to choose those results. You have the power because no one can make decisions for you. And that's huge, because very often people are very used to people making decisions without consulting them, without involving them. And so when people are given the power over choices, even if they're not the greatest choices, that can be a huge resilience builder, because it helps them decide and helps them think things through. And that's where being collaborative comes into play too. People are the experts in their own lives. People are the experts in their own communities. And that shared power, that collaboration, knowing what people need, that all comes from them, not from us. And that's particularly true if you are working with a community that you are not a member of. And so being collaborative, asking people what their needs are, asking them what their experiences are, hugely important. And that can be from, what would you like to do today, to all the way to, is this organization, is this program relevant to your life? Is this what you need right now? And if it's not, what can I do to help you get what you need? And sometimes the answer may not be what we need or we want, rather, but what it is again, that providing choice and that empowerment and working towards their safety and their goals. And empowerment, again, of recognizing leadership even outside of our traditional pathways of saying, like, I'm not the expert in everything, you know more than I do on this. And that's both true with communities and staff too. Are we as supervisors looking at our staff members and saying, like, hey, Mary, that's my intern this semester, Mary, what do you know about this topic? I don't know everything about it. Can you give me your insight? Can you give me your feedback? And then it's also that same thing with community members or students. What do you know about this? What am I doing wrong? What can I do better? Asking that, because that's also that huge part of shared power and knowledge. So our takeaways for today, hopefully you're walking away with this, is that trauma is common in all populations and communities, and that includes staff. It can be experienced on individual, community, and systemic levels, and it impacts our health and well-being, as well as work, patient, client, student outcomes. But with the right relationships and support, trauma is not destiny. Resilience can be built and strengthened at any age. And as y'all go through this program that Ingenuity has put together for y'all, that Courtney and Nicole have put together, and all these great trainings from our partners, you're going to see all of these different ways that you can integrate this knowledge into your work. And I'm really excited to hear from those of y'all in the arts world about ways that you're already doing this, because organizations who promote equity and trauma-informed practices see resilience and thriving in staff and communities. And so, again, some of this you might already be doing, some of this you might already know about, and maybe you call it a different thing or have different ideas about it. But as you take this journey over the next several months, I'm really excited to hear more about what y'all know already and where you can see some of these ideas in your work, and where you envision this